Right, hello and welcome. Fantastic that you made the time to join us today. My name is Eleni Giokos. I'm a correspondent for CNN. I see a lot of you are still joining in. We're about to start off our panel discussion. So we're just waiting for a few more people to join in before we get started. All right, fantastic. I think everyone is out of the waiting room and officially in the program. Thank you very much. As I said, I'm Eleni Giokos. I'm a correspondent for CNN. My real name, my Greek name is Eleni Giokos. And of course, I'd also like to welcome all our friends in the Greek community and of course, all the people that are joining us today. Kalispera σε όλους τους Έλληνες ομογενείς και φιλέλληνες. I'm delighted to be with you today and to be handling this webinar. Theme today is COVID-19 myths and vaccines. And this webinar, and a big thank you to the Hellenic Federation of South Africa in association with the Hellenic, Italian and Portuguese Alliance. We have a lot to discuss. It's a pertinent conversation we're having at a very difficult and tumultuous time, and the pandemic, of course, is still very much with us. I'd like to offer you the opportunity to ask questions to our panelists. You'll see a Q&A tab on the top of your screen. Please send us your comments, your thoughts, any questions you'd like me to pose as we evolve this conversation. It'll be an hour and a half, so we have plenty of time to get through all the issues. Right, so whether it's children and families at home or executives in boardrooms and in government as well, there's one big question that's been plaguing us for over a year now. It's been dominating our conversations, and the big one is, when will the pandemic be behind us, and just how much more pain do we need to endure? To answer that, we need to understand where we are with the vaccine rollout, the efficacy of vaccines on the variant that has emerged in South Africa and others that have emerged in other parts of the world. So what does it mean in terms of the procurement of the first generation of vaccines? Are they safe? And when will they be available to all of us? And what does the future hold? So just a few weeks ago in South Africa, we were anticipating the Astrozenica vaccine. And when it arrived a few days later, we were hit with the very disappointing news that the efficacy against protecting against mild and moderate cases of COVID-19 had dropped significantly. And trials are still being conducted in terms of what it means for the severity of illness. But of course, this was enormously disappointing. Firstly, very expensive to procure. And secondly, what does that mean in terms of protecting our healthcare workers, protecting our children and the elderly? These are the questions that many people are asking, and now we are under new trials, and of course Johnson & Johnson seems to be the one name that we are now discussing. But again, a lot of uncertainty in what that means for us in South Africa. So today we aim to demystify some of the biggest myths, the misconceptions, and the realities that are facing us. And a lot of this comes down to trust of government procurement, of distribution. So from the laboratory to the arms of us, of humans, of people on the ground, that value chain matters. So tonight, joining us, we have a fantastic panel, experts within the industry, and very honored to be welcoming all of you. Professor Barry Schoub, he's the head of the Ministerial Advisory Committee for COVID-19 vaccines. It's a name that we've come to love and know in South Africa. He's been working non-stop during the pandemic. He's a world-renowned virologist who has been a vital voice in the country for decades, including dealing with HIV. We are joined by Stavros Nicolaou, Senior Executive Strategy, Aspen Pharmacare, also the Chairman for Business for South Africa Health Working Group. He's been instrumental in government's reaction to the pandemic. Of course, in terms of what business has been doing from the very start, and from what I hear, very little sleep, working non-stop for the past year. Joining us from London, we've got Dr. Dimitri Kontogeorgis from the Royal Berkshire Hospital in the UK with a focus on emergency medicine. Joining us, of course, from London, who'll be giving us perspective from outside looking in, but also having dealt with one of the more aggressive first waves in the world that has been devastating on the healthcare system there and, of course, on lives in the UK. And now, of course, the UK also dealing with its own variant. So I'm going to hand now over to each panelist who will give us a short update and put things into context for us of where we are right now. We're going to start off with Professor Schoub. Thank you very much for joining us. An absolute honor to have you with us. And thank you very much for taking the time. I hand over to you now, sir.
Good evening, and thanks very much, Eleni, for that introduction. I'm very gratified for being here. Let me thank also Stavros for inviting me, and the Hellenic Federation for hosting me. So it's a great honor, it's a great privilege for me to be here. So let me start off. Where are we with the COVID pandemic in South Africa today, towards the latter part of February 2021? Well, we've just, as probably everybody knows, we've just come out of our second wave. In the height of the second wave, we were seeing anything from about 20 to 20,000 new cases every day. We're now down to just under 1,000 new cases. So it has come down, but of course it hasn't disappeared. So we are at a kind of a grumbling, low-level epidemic at the moment. So, and the reason I'm mentioning is this, that we really can't let our guard down. We do still need to keep up with all those non-pharmaceutical interventions, which we know so well. But of course, I think what you really mainly want me to talk about is where we are with regard to the vaccine. As Eleni pointed out, there was a lot of anticipation. Of course, we had a little bit of a delay. We can maybe come to that a bit later in the program, why there was a delay. But we have started a little bit after, for example, the United Kingdom, United States, and much of Europe. And then there was, of course, a lot of anticipation that we would start off very soon after the Astrozenica vaccine came about. So why in fact did we put a temporary hold on AstraZeneca and then replace it with the Johnson & Johnson vaccine? A lot of people are asking this. A lot of people are, I guess, concerned and anxious because of the anxiety, and has this been a bit of a letdown? So let me explain what happened. Basically, we started getting, I guess, alarming signals from the laboratory, or worrying signals from the laboratory. The laboratories were testing individuals who had recovered from the first wave, which was due to, can I call it the parental strain, the original strain of the COVID virus. And what they were showing is that people that recovered from them, when they took their blood and they tested whether they had neutralizing antibodies against a new variant, there was a dramatic decrease in the ability of that blood to have neutralizing antibodies to neutralize or to protect cells against the new variant. This variant we started isolating or detecting towards the end of October and really into November. We'll talk a little bit later about the variant, how it came about and what the implications are. But it is a sort of a kind of a change in the genetic structure of the virus, which allows the virus to escape the immune system. So then we tested antibodies coming from individuals that had been vaccinated. And this is where really the kind of first alarming signals came about. Because when we tested against, in fact, many people that had many vaccines of individuals that had been vaccinated, we again found that there was quite a remarked decrease in the ability of them to neutralize this new variant. So this new variant was really a tough little guy, and he was able to, he learned the trick of how to escape the immune system. Now this, of course, in the laboratory doesn't necessarily mean, I must emphasize, that this is how it's going to behave in the body. The body's immune system is a lot more complicated than that. However, it was certainly alerted us to kind of look further. Then we got the million doses landed of AstraZeneca, and there was a lot of fanfare when it did land. And then soon after that, they analyzed the results of the trial of AstraZeneca. Now, the AstraZeneca vaccine was trialed in South Africa. It was a relatively small group of volunteers that was looked at, and unfortunately, it was a group that didn't include any of the elderly people or people that had comorbidities, so we couldn't really tell, was it protecting against that. But when you looked at what it was, how it was performing in the group of relative young individuals, this was very disappointing, because on the previous virus strain, it had about a 70% protection. But against this new variant, this went down to about 22%. And in fact, if you looked at a subsample of individuals that were infected with the variant, the protection went down to probably in the teens. So we were really faced with a problem. We had 1 million doses landed in the country with a vaccine that we really ethically couldn't justify giving, particularly to our healthcare workers, which were the kind of frontline, the first priority of individuals who would need the vaccine. So we took the decision, it was a painful decision, to to stop the Astrozeneca vaccine, to at least put it on hold until we get more data, and particularly until we get data from elderly individuals or people who are likely to get severe infection. Because if it did protect against severe infection, if we did get that data, there may still be value in it. And we're still waiting at the moment. At the moment, we've suspended using AstraZeneca for that reason. Unfortunately, along came Johnson & Johnson. This is a vaccine which has been trialed in South Africa with the variant and shown reasonably satisfactory performance, about 57% protection against mild or moderate disease, but very importantly, about 85% protection against severe disease, because fortunately, this trial did include elderly individuals and individuals with underlying illness. So we are very fortunate, and Johnson & Johnson have been absolutely magnificent. They have supplied us with the vaccine. We're getting, we had the first tranche has already come of 80,000 doses, which means 80,000 individuals, because it's a single dose vaccine. And already over 40,000 healthcare workers have already been vaccinated. And that program is going very well. Obviously, there are some glitches. The media love picking up on these glitches. But overall, the program is going very satisfactorily. And I said 40,000 healthcare, upwards of 40,000 have already been vaccinated. So I'll leave that as the kind of background of where we are in terms of the disease, in terms of the pandemic, and in terms of the vaccine rollout. And maybe later on the program, I'll maybe expand on where we are in terms of how the vaccine will be rolled out to various groups of individuals, and how the vaccines, or vaccines in plural, will be acquired over the course of the year.
Thank you so much, Professor Schoub. Really fascinating, and so much for us to work on. Thank you very much for that update. Stavros, over to you, sir. Just a reminder, Stavros Nicolaou is from Aspen Pharmacare. I see we've got so many incredible people joining us. I just want to thank you once again. I see we've got some journalists that are online. I see many questions that are coming through, many myths, many misconceptions that we're going to be addressing. And I look forward to addressing those in just a short while. But for now, Stavros, over to you.
Eleni, thanks very much, and good evening to my fellow panelists, and to all the colleagues that are watching this program this evening. I'm going to, in a couple of moments that I've got, from a private sector perspective, complement what Professor Schoub has outlined. So he's given you a very exacting and precise update on where we are at this point in time as a country, both with COVID and where we might be with the rollout of the vaccine. Perhaps what I should emphasize is that the intention of our country, the stated intention of our government, is that we need to vaccinate 40 million South Africans over roughly a 12 to 18-month period. That is all in order to achieve what we call herd immunity. I think there'll be a little more unpacking of what herd immunity or the epidemiological endpoint means. We'll cover that later on in the program, no doubt. But I wanted to place in perspective what the challenge is. It's 40 million South Africans that need to be vaccinated over that 12 to 18-month period. This would be carried out in 3 phases. Phase 1 is the phase that we're currently busy with. The phase 1 targets around 1.3 million healthcare workers. These are doctors, nurses, and other support staff that work in healthcare facilities and have an exposure to the vaccine, to the pandemic, I should say. The second phase, which is a phase that will commence sometime in Q2, that's the quarter April to June. The intention there is to vaccinate what we call essential workers, and also what we call high risk, the high risk segment of the population. I think you all would have read that the high risk groupings in our country and in the rest of the world, insofar as COVID is concerned, include your diabetics, people with cardiovascular disease. So these are people with underlying conditions that can exacerbate the impact of the virus. So that's the high risk population, and the essential workers will be covered in that second phase. It's envisaged, and of course don't hold me to these timelines because the environment is fluid. I'm just giving you a sense of what government is planning here. That second phase is planned to commence in Q2 and to end in the beginning parts of Q4 of this year. Thereafter, and incidentally, it's proposed that around 18 million people living in our country would constitute phase 2. So there's 1 million in phase 1, 18 million in phase 2, and then the balance being about 21 million people living in our country. And I'm very carefully saying people living in our country rather than South Africans, and I'll explain why I'm saying that in a moment. The third phase, which will cover 21 million people, is your less risky populations. So that's what's envisaged. Professor Schoub has given you a good sense of where we are right now. We need to, as a country, outline what the supply pipeline looks like. The private sector is highly engaged and involved in making both introductions to would-be suppliers and or manufacturers, and where we can, supporting government, whether it's contractually or otherwise. We don't carry out the procurement. The private sector will do no procurement of vaccines. It will be the government. But we are, as Business for South Africa, supporting government at a number of levels to A, secure this pipeline of product, and B, to ensure that these contracts that are required are timelessly both initiated and completed. So to touch on again where we are right now, we have secured 500,000 doses of Johnson & Johnson product. This has been donated by Johnson & Johnson. It's for clinical trial purposes. It will only go to healthcare workers exclusively in that first phase. And that will tell you that if we need to vaccinate 1.3 million healthcare workers in phase 1, that gives you a deficit of around 750 to 800,000 doctors and nurses that we still need to cover. So what this means, and there are some other manufacturers like Pfizer that will supply product towards the end of Q1. There are some supplies coming in Q2. And I think this is what people are anxious to find out. What does this pipeline look like? We're not going to answer that fully this evening. I can only give you a sense of where in our discussions with government, which on a daily basis, where we understand the picture to be. So in Q1, we're going to have some deficit. We're going to have a dearth of vaccines as it stands today. Of course, this picture can change in Q2. And then it significantly ramps up in Q3 and Q4. So right now, Eleni, we have a short-term problem, end of Q1 and end of Q2. And that's why we, as private sector, together with government, are highly engaged in trying to see how we can accelerate, where possible, supplies of vaccines that are suitable for our country in Q1 and Q2. And my final comment on this is, as I indicated earlier, government is doing all the procurement. Private sector is supporting and complementing. There's a very specific reason. I know many of you have said and asked me, why is the private sector not doing the procurement? They could do this more efficiently and all the rest of it. The answer is very simple, that if it's left to the private sector, you will only get private sector coverage, which is about 7 to 8 million people. We need to vaccinate 40 million. So we cannot have this uneven distribution where the private sector gets vaccines, the public sector doesn't, and then you're never going to solve the herd immunity problem, because we have to work on the mantra that everybody, you're only safe if everybody is safe. So there's got to be an even acquisition and distribution of these vaccines. And that's why these drug companies are dealing directly with the government and not the private sector at this point in time. Thanks very much, Eleni.
Thank you very much, Stavros. I really appreciate it. Of course, it is a race against time, isn't it? And I really find the comments on the private sector involvement really interesting, because there's so many parts of the value chain that the private sector would be able to cut across. I'd like to now hand over to Dr. Dimitri Kontogeorgis from the Royal Berkshire Hospital in the UK. He has a presentation prepared for us to give us a sense of what's going on in the UK. And I'm going to reiterate this. The UK, of course, went through a very tough first wave, and now vaccines have already started being rolled out there. So Dr. Dimitri, over to you, sir.
Thanks very much, Eleni. I'm going to just share my screen. So apologies for some slight technical delays. And do let me know if you can see that.
We can.
So everyone happy and can see?
Yes, perfect. Thank you.
Fantastic. Go ahead. So very honored to be on this platform. Prof. Barry was my 5th year virology lecturer, so I've got to put my best foot forward. But we talk about vaccines and we talk about this virus, but at the end of the day, there are patients who are getting infected with this virus, and that's really what I want to focus on today. So I'm going to take you through a patient journey. I have no conflicts to declare. So a patient case that came to us. I'm going to look at some of our local data. So some of the data at the Royal Berkshire Hospital. We are placed in the Oxford Deanery. So some of our sister trusts are Oxford and Wexham Park Hospital in Slough, and Milton Keynes General Hospital. So taking you through this patient journey, I'm going to look at some of the research and some of the updates, and hopefully I'm going to end off with some very positive take-home messages. I'm very, very sorry. There are some graphs to go through, but I won't go through them in a lot of detail. It's purely for graphical representation. I know it's almost 7 p.m. your time, so everyone's tired after a long day at work. But first presentation and graph is, if you look at the very central graph, which is the one with the red line, and that's us over the course of 12 months. So this was my hospital, the Royal Berks, and that's the first wave, so March 2020, and the second wave over November and December, and you can see very clear discrepancies and a very clear spike. And part of the second wave and the increased presentations with COVID to us was because of our variant, the UK variant, basically the mutation that we faced. So we had a tough first wave, but we had a much tougher second wave. So that central graph is pertinent to this presentation, and these are our ICU figures. So if we look at April last year, we had approximately 30 patients in ICU, and compared that to only a couple of weeks ago, we had over 40 patients in ICU. We were an 18-bedded ICU, so we were at 200% capacity. And 2 weeks ago, we were so stretched that we were actually sending patients out of our ICU. We had no space. So we sent a patient to Oxford and we had to send a patient to Southampton. So it was a tough day for everyone. And this was a case we saw. So it was a 35-year-old female who presented to us, young, fit and well, 2 children at home, and she presented with some non-specific symptoms. So she had a few days of vomiting, headache, some mild diarrhea, a bit of tummy pain. She called an ambulance, so SCAS is South Central Ambulance Service. She was given some fluid, she was given some antiemetics, and her observations were not too bad. She was a bit tachycardic, tachycardia. Her oxygen level wasn't too bad, 97%. Her blood sugar was a little bit low, so she was given some dextrose, but she had a stable blood pressure, she had a high fever, but she was alert and awake. So she came into us, and I'll gloss over some of the detail. She actually, with a bit of fluid and some supportive management and assessing her observations, she was quite stable. And the crux assessment that we do in A&E is we check the oxygen level. Of all the observations that are sort of game changers for us, it's the oxygen level and it's exertional oxygen level. So in other words, what we'll do is we'll do a walking test. So we apply a SATS probe and we walk the patient through the department. And this patient's walking SATS didn't drop at all. So good signs all round. And this was her X-ray. Her X-ray was pretty normal. So good-looking X-ray. She had slightly raised inflammatory markers. She had slightly decreased white cells, which is in fitting with COVID. And then we did a point-of-care COVID swab, which is a test whereby we can get a swab result and confirm that a patient has COVID within 30 minutes or sometimes 90 minutes. So we have 2 different types of analyzers, and I'll talk a little bit about that as the presentation goes on. goes on. So in terms of some of the updates, we've been involved in a study called the pre-study, and what that looked at was the triage methods at predicting serious complications. And again, we know that there's certain variables that are standard, and there are certain variables in COVID that are particularly helpful. And as I mentioned, oxygen level and oxygen saturations is particularly important. And a subgroup analysis of the pre-study was looking at post-exertion oxygen saturations. We do a standard chest X-ray or a point-of-care lung ultrasound. We do an ECG on patients, so a heart tracing. And what we know now over the course of 12 months and a lot of learning is that we have some blood markers that help us, that serve as prognosticators. So they can tell us through trend analysis how a patient will do, whether they will deteriorate or whether they can be discharged at a sooner time. And in terms of point of care testing, so if I just share my example, a year ago in January, I recall seeing the first patients who were arriving from Wuhan. And at that time, we were taking samples and sending them off to a central lab. And the turnaround time of that swab result was about 4 days. And now in my ED, I can get a COVID result on a patient within 30 to 90 minutes. So a lot of improvements there. And for the audience members who watch football, a lot of progress on point of care testing. So the Falcon trial, there's a point of care test called the Menarini test. So a lot of Premier League football clubs are using these point of care tests to allow them to test their players regularly and then to be able to sort of partake and protect their players and partake in football games. So that's where things are evolving. So a lot of progress in 12 months. Some more data, and I'll just gloss over, and I'll just highlight the most important things. So we submit all our data to a consortium called ASARIC. So it's a lot of demographic details on how patients perform, how many patients get discharged, sadly, how many patients die, how many patients need critical care, and so forth. And I'm drawing your attention to this inverted triangle effectively, and the very central blue part of the triangle, so the dark blue part. And that represents the patients who've sadly passed away because of COVID. And it's actually, as time has progressed, it's actually become better. So we are discharging a lot more patients who need to be hospitalized. So that's good. And just some of the demographics that have been sort of captured and that have helped us over the past 12 months is we know that males are more critically ill with confirmed COVID. We know that certainly in the UK, Black and Asian ethnic minority groups perform worse, so they become more critically ill with COVID. We know that patients who, and this is, you can extrapolate this data to the South African context, patients who come from deprived backgrounds, so social and economic deprivation, those patients are more critically ill with confirmed COVID. And then we also know that body mass index is vital. So the data shows that if you're overweight, you will do worse. So BMI is pivotal to how patients will do, and patients with a high BMI again become more critically ill with confirmed COVID. And one of the things we launched was in a pursuit to kind of protect the NHS and hospitalize those patients who only needed to be hospitalized was through using pulse oximetry. So as an oxygen probe that goes onto the finger, we were able to actually discharge patients back into the community with telemonitoring, remote monitoring. We could then monitor their oxygen levels through daily sort of conversation and contact. And in that way, we could actually keep patients out of hospital through remote monitoring. And we had some very good success through this TIC-19 pathway and a study that we published. So the case continues. This lady had daily follow-up as part of the TIC-19 pathway. Sadly, she deteriorated. She needed to be readmitted to hospital, and she had a worsening oxygen level, but she wasn't requiring ICU. And at this point, it'd be good to interject and just look at some of the big trials that we were involved in as a recruiting site for sort of the therapeutic management of COVID. So one of the trials is the recovery trial, and I'll just give you guys the highlights. So azithromycin, so many will know it's an antibiotic, but it also has immune-mediated properties, showed no benefit. Convalescent plasma, so that's patients who've had COVID who then went on to donate their blood. So that's kind of taking blood with antibodies from patients who've had COVID before and transfusing that into patients to help them get better. That showed no benefit. Hydroxychloroquine, which again was lauded by President Trump, showed worse outcomes. Patients on hydroxychloroquine don't do well. Coletra, which is an antiviral, again showed no benefit. And then the recovery trials showed good benefit with dexamethasone, a steroid that's cheap, that's accessible, showed good benefit for patients who are needing oxygen and need to be admitted. And then recent data shows tocilizumab, so some patients in the audience who might have rheumatoid arthritis, who might be on this drug, again, giving it to patients who need oxygen, so the moderate to severe group, they benefit by being on this drug, on tocilizumab. And there's the jury's out on some of the other arms of the recovery trial. So we're looking at colchicine. So again, members of the audience who might have gout and might be on colchicine. So we're looking at whether this helps improve outcomes for patients with COVID. We're again exploring Regeneron. So again, President Trump was on Regeneron, this synthetic monoclonal antibody. We're looking to see if that's effective. We're looking at aspirin, pure old, good old cheap aspirin. And then finally, we're looking at baricitinib, which is also a monoclonal antibody. And there's some evidence, and I'll just gloss over the ATTACK trial, the REMAP-CAP Active 4, which looked at the risk of thrombosis. So we know that some patients on COVID, about 5 to 30% are more prone to clots. So we put them onto blood thinning medicines to help prevent those clots. We also looked at a drug called remdesivir that Prof will know quite well. It's an antiviral. It's been used in patients with HIV, and this showed some moderate benefit in one study. So there was shortened recovery from 15 days to 10 days with a trend towards survival, but it's quite controversial. And there's been a recent publication, the WHO Solidarity Trial, which recommended against the use of remdesivir. So let's go back to our patient, and we look at this X-ray, and clearly our patient was getting worse. She needed to be on non-invasive ventilation, so that's a mask that's attached to the face. We give oxygen at very high pressure. That didn't help, so she needed to be in ICU. She was admitted, was put on a ventilator, and she deteriorated to such an extent that she needed to be transferred to a specialist center for something called ECMO. And despite that, she actually did quite well. She did well with the ECMO, and these are her pre-ECMO and post-ECMO CT scans. You can clearly see the one on the left looks a lot worse than the one on the right. And this is her now. So she was repatriated post-ECMO. She had a tracheostomy that helped her get off the ventilator. She was transferred to a ward, and then she was discharged home, I think, a week ago. So she'd been mobilizing with a frame, and my wife, who's an ICU consultant, saw her in a follow-up clinic, and she's doing well. She's got survivor's guilt. She's got some post-traumatic stress disorder, but other than that, she's doing okay. And
I mean, I was like, what happened to the patient? I was waiting for the moral of the story.
Because at the end of the story, there's a patient who's at the end of this conversation. Yeah.
So I'm glad she survived. That's really good news.
And we've all had loss, haven't we? Had loss as a result of this pandemic. So a really positive slide is that if we look at the slide, we've got this is a national trend that shows that in the first wave, our death in ICU was about 50% of patients were dying, and the national figures now show in the UK that about 30% of patients are dying. So we're clearly getting better at how we manage things. And from sort of my patch of the woods at my shop, it's about 40%. And now we've gone down to 20%. So marked improvement in survival. Last two slides, I'm almost there. So we have greater knowledge about the virus. There've been advances in triage and prognostication, advances in point of care testing. We have a stronger evidence base that's been supported by large trials for therapeutic options. And this is where our leaders play a pivotal role in giving the public accurate information. We know about oxygen support. We know about the benefits of NIV and IMV and proning patients. And there are more trials and evidence on the horizon. And of course, the vaccine rollout. And the very last slide is 2 days ago, Prof. Whitty, the CMO, shared at the Downing Street briefing some results from the Siren Study. So this was healthcare workers who were vaccinated, and we looked at their antibody response to the vaccine. And with just one single vaccine dose, and I think this echoes the Prof's figures, the risk of catching infection was less than 70%, and that rose to 85% after the second dose. But it's not 100% effective. But what we have found through the Siren studies that the patients who've been vaccinated and still go on to get COVID, and we've had cases like that, they present with a much milder infection. So it's all looking promising, and it's been a tough 12 months. So that's it really in a nutshell. Some thank yous and my email. If anyone in the audience wants to ask me some questions or email me privately, I'm happy to share the presentation. I have more data if you'd like data, but that's it. And I'm sorry if I went over time.
You did. Doctor. But you know what? It was really interesting. And I think we all wanted to know what was going to happen to the patient. So we're really delighted she was able to make it through. We have so many questions, and I'm getting a lot from the audience as well. I'm glad that you're touching on some of the myths and some of the misconceptions that have been coming through as well. So keep those coming, and we'll pose the questions to our panelists as the conversation goes on. So, Professor, I would like to now come to you. And I guess the big question now is just what vaccine options do we really have? And what are most suitable for South Africa, given that the variant shows to have created a lot more uncertainty. In fact, when the variant started emerging globally, that was the big question, is just what impact would the first generation of vaccines have on these variants? So we've been highly disappointed with AstraZeneca. We've got China as an option, the Russian vaccine as an option, and of course a lot of other global players. So where should we be focusing our attention? Yeah,
thanks, Eleni. We actually have grouped the vaccines. Let me take one step back. They're actually close on 300 candidate vaccines which are being developed at various stages, from the laboratory to experimental animals to the trials and so on. So we've narrowed it down to really three groups. The one group are vaccines which we are confident will have therapeutic benefit for treating at least mild and moderate infection, but certainly, and this is the main thing what we're looking at, severe infections. And those are Johnson & Johnson vaccine and the two messenger RNA vaccines. That's Pfizer and Moderna. That's the one group. The second group are vaccines which we think probably will be therapeutically beneficial, but unfortunately we don't yet have that data. And that's the Russian vaccine, codenamed Sputnik, made by the Gamaleya Institute, which in fact has published its phase 3 trials and has in fact got a 92% efficacy, which is remarkably good for a vaccine which is made on that particular platform using adenovirus. And also the two Chinese vaccines, Sinovac and Sinopharm. The problem with the Russian vaccine is that we don't have data with the variant. The problem with the Chinese vaccines is we just don't have data, full stop. You've got preliminary data, the phase 1, phase 2 trials, which look very good. These vaccines seem to be quite a good stimulator of the immune system, but there's no clinical data. The Russian vaccine, we don't have data for our particular variant, but there is good clinical data. So that's where we are with the second group. The third group is the AstraZeneca and vaccines like Novavax vaccine, which we think on the data so far are not suitable for South Africa. Now I say so far, this is a moving target. We are learning, things are new, it may change. That's where we are with the three groups of vaccine at the moment. So we started the rollout of the Johnson & Johnson vaccine for the healthcare workers. We are soon getting in Pfizer vaccine, which is the messenger RNA vaccine. I think about 20 million doses are promised probably around April, May time. A smaller amount, about 117,000 coming earlier from the COVAX facility. And that should really take us right through, I think, probably till about the middle of the year. The other vaccine negotiations are still, there are non-disclosure agreements. So I'm not privileged to the information. So you can torture me as much as you want to. I can't give that information because I just don't have that information. Stavros might have it, but I don't. And I think this is where we are. We are getting the Pfizer that has been promised to us. We are getting another big tranche of Johnson & Johnson vaccine. That's about 9 million doses. That's also coming towards the second quarter of the year. But you must remember, it takes some time to actually roll out these vaccines. So we will have vaccines which will continue the rollout process, carrying out, as Stavros mentioned, throughout the year.
Yeah, I mean, Professor, and here's the reality, as you say, we haven't done clinical trials in South Africa on the variant. There are so many vaccine options, and yet we need to procure and we need to pay for these vaccines. And it's a costly exercise. And there's problem, because the South African government, our government, does not exactly have very deep pockets. We're already facing a financial crisis, basically, even prior to COVID. The bill is going to be enormous. How do we reconcile that? Because it's a race against time. You've got to do these trials to see what's going to work. I mean, what is the best way forward?
Look, I think we do have to go on scientifically based evidence. We can't just be, and I think the one thing we have learnt is that there's a lot of pressure out there, but we've got to resist the pressure. We've got to look at what the scientific evidence is, because we are playing with people's lives. And not only that, you must remember that we're immunizing healthy people. We've got to be assured that these vaccines are safe and that they are effective. And we can't play around with that. So we've got to use good scientific evidence to make those judgments. But you're right, it is a moving target. And you must remember, these are our first generation of vaccines. Vaccines will improve. And there's a lot of research to improve, particularly to deal with the variants. And variants are popping up all over the world. Even in Dimitri's country, there are now not only the B117, there's also the more sinister one. The one similar to what we got is now starting to be, I don't want to scare you, whether the 117, which is the highly infectious one first isolated in the UK, we're hoping, or they're hoping, that that's going to displace the more sinister one, with the one with the 484 variant, one which makes it resistant to antibodies.
Okay,
so
you mentioned safety, and I think that's the big thing for people watching right now. Can we trust these vaccines? Are they safe? They were produced in record time, and as you say, clinical trials are still on the go. I think that, we've had so many questions from the audience already on safety. Let's deal with that elephant in the room right now, and then I'm going to move over to Stavros.
Yeah, Eleni, I don't know how many times I've been asked a question about safety.
Yeah.
So this is a very valid question, a very acceptable question. People are hesitant, and they've got every right to ask about safety, because these vaccines have been developed in less than a year, and normally it'll take anything from 10 to 20 years to develop a human vaccine. And also, these are novel platforms. We've never had messenger RNA vaccines in humans, and defective adenovirus vectored vaccines in humans. So they're asking good questions. I think that the thing is, what we can reassure, the reason that these vaccines have been done so quickly, have been made so quickly, is a reflection of how sophisticated our science of vaccinology is. In other words, the science of developing vaccines and research. We have now reached such a sophisticated, in-depth scientific level that we can develop these vaccines so rapidly as we do. And I think also it gives a reassurance that the safety monitoring is also at such a scientific depth. Now, the one thing I do want to mention is that the safety monitoring goes all the way back from the phase 1 trial, even before the phase 1 trial. There's an independent data safety monitoring board which monitors the vaccine trials from phase 1 to phase 2, phase 3. After that, there's a 2-month waiting period, safety waiting period, before it goes to what's called a stringent regulatory authority, usually the FDA in America, or maybe sometimes a WHO pre-qualification, where again it's stringently looked at, and then it comes to the local regulatory authority. In our case, it's called SAHPRA, South African Health Products Regulatory Authority, SAHPRA. I've been involved in those trials, and I must tell you, the dossiers that come are almost in the truckload. Massive dossiers looking at every constituent, from the water to the glassware, as well as the trial data itself. Now, obviously, if vaccines have been licensed overseas, a lot of that is shortcut, whatever the verb is, shortcut. But the reassurance of the safety is that goes all the way back with very in-depth science. So these vaccines are remarkably safe. And up to now, what millions of doses have been given, and the safety record has been remarkably good. Of all these vaccines, Astrozenica, Johnson & Johnson, Pfizer, they've all been extremely safe vaccines.
Thank you, Professor. Stavros, Aspen is on the cusp of producing the Johnson & Johnson vaccine at your plants in Port Elizabeth. I think what many people need to understand, and you mentioned this in your opening statement, that it's currently under trial right now. It's not registered. We know no vaccine in South Africa, as the professor just said, has been registered in the country as yet. Tell me where you stand right now. Some of the people I've been speaking to say, well, we're going to be producing Johnson & Johnson vaccine in South Africa, which means that that's the vaccine we're going to get, and it's going to happen really quickly. But there's so many other moving parts we need to consider.
So, Eleni, I am slightly constrained in what I can say and what's out in the public domain. So let me answer as follows. Firstly, the J&J vaccine is in fact not still under investigation. They've completed, as you would have seen, their phase 3 trials. This was around 3 weeks ago. Professor Schoub alluded to the efficacy rates and the safety profile that these trials demonstrated. So it is fit for purpose for South Africa. The next step, of course, once you complete these studies, is you then file for registration. The various drug regulatory agencies around the world. J&J have made it public that they are filing around the world, including here in South Africa. They've also made that they've made it known that they're doing what is called a rolling submission. So once these drug regulatory agencies independently, and I must stress the word independent here, because this is what they do, and this speaks to an added assurance around the safety, is that this data is independently reviewed by experts that are contracted by these drug regulatory agencies. They make an assessment on the drug, and if they're satisfied as to its efficacy and safety, they then go ahead and register the product. So it will be no different with J&J in South Africa. I think it is well known that J&J have contracted 7 manufacturers around the globe, including the South African company Aspen Pharmacare, and Aspen Pharmacare will be producing the finished dose, what we call finished dose product here in South Africa. I'm unfortunately constrained in terms of letting you know the timing of this, because there are a couple of steps that you need to arrive at before you can go out public with time frames here. But suffice to say that J&J are aware that a product that is going to be produced in South Africa, there's generally anxiety to find out when it will become available. So I think as and when the next steps are satisfied in this process, J&J will come out publicly.
So if I may be bold to just, kind of push slightly, see how much I can get from you. So I know that Johnson & Johnson, you're basically contracted to produce the vaccine. So you're producing a certain amount of vaccines. I think it is 300 million, Stavros, doses.
So we've indicated publicly that we can manufacture up to 300 million doses. The exact quantum that we will make has not been determined yet, but yes, we have capacity in this country to make 300 million doses. And of course, the J&J vaccine, as most of the viewers will recognize, is a single dose vaccine. That's in fact the only one. There's a Chinese one that's also single dose, but that means that you're making up to 300 million doses, which covers 300 million lives if you maximize the production.
And this is going to be exported to various places around the world, depending on Johnson & Johnson and the procurement they get. But here's the argument, because you're talking about, herd immunity, and many people want to know, when is the vaccine going to be available, any vaccine going to be available for the masses? When I think of a 40 million number versus the 300 million that you're capable of producing, what needs to happen to actually get a Johnson & Johnson vaccine rolled out quickly, effectively to South Africans? Does government need to get involved? What kind of conversations need to happen so that can actually be a reality?
So look, Eleni, obviously the J&J vaccine, as Professor Schoub and our government have indicated, is at this point in time one of the preferred options. One of the reasons it's a preferred option is not only its safety and efficacy, but also it's a single dose vaccine, as I indicated earlier. So with all the others, you have to do a 2-dose shot. So in other words, you administer one today, and then 4 weeks later you come back for the second dose. Now that immensely complicates the logistics. It increases the cost, and there's also there's data that indicates that when patients present for a second dose of the vaccine, many of them actually don't turn up. So that in itself affects your ability to get herd immunity. So there's no doubt that there is immense benefit with the J&J vaccine. It's not the only option, let me be clear on that, but it does offer immense benefits. And of course, J&J and our government are in discussion in that respect. And I think that's all I can say at the moment. To answer your question, who needs to enter the fray in terms of those discussions, I think those are already in progress, and we're hoping for a good outcome.
Well handled. Thank you very much. It was a good answer. Dr. Dimitri, look, you know, when we started to see vaccines becoming a reality, you had richer countries with, you know, a lot more resources procuring quite effectively. And the World Health Organization at the time came out and said, we're really concerned about richer nations hoarding vaccines, and then that putting very big pressure on the likes of low-income countries and medium-income countries. From your perspective, and someone that is in the healthcare industry, are you concerned that we've been left behind? We see images of people getting vaccinated in the UK. It's exciting. We're hoping that's going to be our reality, but it feels like we're behind.
It's difficult to comment on the South African perspective. I think there was a time when the UK felt like we were behind other countries, and I think the UK has been in a good position in the sense that one of the first vaccines that was rolled out was the Oxford vaccine, and that was, you know, made available to us as a trust, being sort of a neighbouring trust to OUH, or Oxford University Hospitals. So we were in a good position in that we had kind of a, if you will, a national/locally developed vaccine that was ready for use. So difficult to answer that. I think every country has battled through this. I think there's been a lot of criticism directed at the UK government in terms of how it's handled the pandemic as a whole. The one thing it's done fairly adequately has been the vaccine rollout program, and sort of engaging with the scientific community rather. But yeah, in terms of in terms of kind of accessibility, I've been vaccinated. I opted for the Pfizer vaccine just because it was more accessible to me. But I've had colleagues who've had the Oxford vaccine, and I think just the other comment to make on the UK approach is and they've probably deviated a bit from scientific evidence is as you well know, is they've gone for a more scattergun approach. So yes, these vaccines have been developed with an evidence base that suggests a patient should be vaccinated and then 3 weeks later get their second dose. And what the UK government has done has said, to ensure we vaccinate a larger proportion of the country, and to aim for, as Stavros was saying, that 80% vaccination rollout, is we're going to give or ensure that everyone at least gets one dose of the vaccine. So, for example, I've been scheduled to get my second dose, in early April. So they've gone for a less evidence-based approach to this. They've taken a bit of a gamble. For the moment, it seems like that gamble may be paying off, in the sense that today's figures, almost a third of the country have been vaccinated. So we're almost at 30%.
So here are a few questions from the audience. So I'm going to read out a couple, because I think, Dr. Dimitri, you'd be able to touch on these since you are already in the middle of the vaccine rollout. So the one question is the Johnson & Johnson single vaccine as effective as the Pfizer double dose? I have had the second strain of COVID. Should I get vaccinated? So there's lots of questions about, how do you pick the right vaccine? You're saying you picked specifically Pfizer because it was, something that was good for you. So I'm sure you're getting these questions from your patients as well. Yes. How do you answer them?
I think so a couple of questions in there. So if you've had COVID, should you get the vaccine? Absolutely, yes. So what we have been seeing, especially with our, as Prof mentioned, our variant strains, is that we are having patients who have had COVID in the first wave and are representing with, second infections. So we are seeing second COVID infection. So having the vaccine is pivotal. We also know that even after you've been infected, your immunity wanes, so your antibodies wane. And there have been studies that suggest that at 5 months, a lot of your antibodies have diminished. So without a doubt, even if you've had COVID, you must get the vaccine. In my mind, there's almost no debate. From a safety point of view, the only reports and perhaps we have a vaccination center within our hospital, is I've seen 2 patients who presented with very mild allergies, and that's it. You're a trust of 5,500 employees, and everyone's been vaccinated or had their first dose. So 2 patients out of 5,500. There must be a good mathematician, statistician in the audience who can tell us what the percentage is, but it's very, very low. So I think it's immensely safe, and I don't think there's a debate really. With all due respect, I think there's just no argument for getting the vaccine.
The trouble is there is a debate, and I've got some really interesting questions that have come through. We'll touch on those. We'll do a fact versus fiction segment today. Professor Schoub, I want to talk about the many comments where South Africans feel that South Africa has failed in procuring in time. The country joined COVAX in December. Some say we were late to the party. There was questions about who procured AstraZeneca without waiting for the trials to be conducted. There's a question from an audience member saying, why do we even trust that trial when, as you mentioned in your intro, it didn't include the elderly? It's almost like there's this lack of trust in the way that South Africa procured vaccines, and now we're sitting in a difficult spot. Yes. You're muted. I knew I was going to say it at some point today. Prof.
I'm sorry. My apologies. There are quite a few questions there, so let me deal with them one by one. Yeah. First of all, I think you touched on it with Dr. Dimitri just now with regard to what's called vaccine nationalism, and I think we are the victim of that to some extent. In other words, the high-income countries could afford to put down their deposits, the non-refundable deposits, at risk last year when the vaccines were still undergoing trials, and we didn't know were they going to be effective or not. We in this country, as you rightly mentioned earlier on, in a far more precarious economic position than, for example, the United Kingdom. And we've got rules and regulations such as the Public Finance Management Act and so on, which are very, very particular about fruitless expenditure. And whatever the reason is, and I think really is an economic reason, this country could not afford to put down deposits on vaccines and purchase vaccines, or shall I say pre-purchase vaccines, at a stage when we didn't know are they going to work or are they not going to work. And so it turned out that we were very fortunate not to have done that, because now we had the variant. I mean, can you imagine if we would have pre-bought vaccines for the entire year? If we were pre-bought 40 million vaccines of, say, AstraZeneca, and then found that it doesn't work, now at least we had only 1 million that we had to kind of deal with, not 40 million. So really that decision turned out for the better. Now, the kind of bottom line there was a delay, that's true, but really not a long delay, a delay of about a month, I'd say. If you look at countries which started off, United Kingdom was one of the first countries in the world which started the rollout. Countries like, for example, Australia, a high-income country, are only starting now. So we actually beat them. And other countries, actually, you might say they control the epidemic. That's more than all the reason why they, in fact, should be vaccinating. So I think that really explains it. And I think, we're all wise. We're all wise with the retrospectoscope. That's what I was taught in medical school, looking back looking backwards. But at the time, we would have been kind of castigated for putting down a large amount of money at risk. And it would have turned out, in fact, that we would have wasted a lot of money. So I think that send them back
if they don't work.
I'm sorry?
Can we not send them back if they don't work?
No, you can't. It's a non-refundable deposit. You only utilize your deposit if you take the vaccine. So I think that's I think that is why there was that delay, which of course caused a lot of kind of pressure. And I think that pressure, to a large extent, particularly the need to have our healthcare immunized, kind of drove the government. They kind of saw that there was a very acute public health need. And that's why the vaccine that was available was the AstraZeneca vaccine. Now, at the time when the AstraZeneca vaccine was purchased, that trial, the efficacy trial, had not been released. We only had some of the kind of laboratories. And AstraZeneca performed and does perform very well. It is being rolled out in the United Kingdom, for example, and it's a good vaccine. We're not saying it's not a good vaccine. What we're saying is that it doesn't work so well against our variant, and that was unpredictable. It was unpredictable. That only came about after the AstraZeneca vaccine landed on our shores, and that decision to suspend it could only have been done after the results of the efficacy trials were released. And they were released. They could only have been released after the vaccines had been purchased.
Thank you very much. Look, I know I was joking about sending it back, but at the end of the day, It's what do you do with vaccines that have now been developed that don't work?
And I can answer that. It is being sent to countries which don't have the variant problem. On the African Union platform, to African countries don't have the variant, or don't have significant variant. And I must stress, it's a good vaccine. We're not saying it's not a good vaccine.
All right, so Stavros, I want you to jump in here. There's a few questions about the Johnson & Johnson vaccine, so I hope you'll be able to answer them. I mean, the one question from Felicia saying that it has the Johnson & Johnson vaccine has a 57 to 84% efficacy against the strain. But according to Johnson & Johnson, sorry, that's according to Johnson & Johnson, but it is considered a therapeutic. Is that true?
So, Eleni, look, I can obviously relay what's out in the public domain again. So I think that the important thing about Johnson & Johnson, they conducted clinical trials around the world. They included a cohort of subjects, patients, in other words, around 6,500 of them in South Africa. So the data that they were able to collect was specific to the dominant variant in our own country, as Prof. Schoub said. And in fact, of those 6,500 subjects that were tested against the J&J vaccine here in South Africa, 94% of them presented with this dominant variant that we're experiencing in our country. So this is the dominant variant that in the second wave, when the cases and caseload was escalating, it was this dominant variant that was largely responsible for that second wave. So Johnson & Johnson have got data with respect to the South African variant, or I don't like calling it the South African variant. Yeah. It happened to be the dominant variant in our country at that point in time. Incidentally, it's found elsewhere in the world, so you can't really call it a South African variant. Let's call it was dominant in our country at that point in time. So they do have the data, and the endpoints you need to look at here with the data is, did it prevent hospitalization? Was it effective against severe disease? And did it prevent mortality, the death rates, right? And in all three of those endpoints, it's an efficacious vaccine to use. Now, is it a therapeutic? I think that was the other question. So you've got two things here. You've got vaccines that are preventative in nature. And in fact, other than clean running water, vaccines are the most, I'm sure you've heard this many times before, other than clean running water, vaccines are the most effective tool known to mankind in preventing disease. So they are preventative in nature. The therapeutics treat the disease once you've got it. So the vaccines prevent the disease, and then if you do happen to get it, the therapeutics treat the disease. So hopefully I've distinguished between the two. A vaccine, preventative; a therapeutic is for treatment.
The other question we got, and I think you'll be able to answer this, in terms of getting support from our BRICS partners, this question is from Sizwe, who are producing the vaccine. Surely we should enjoy some advantage from being members of this bloc.
So, Eleni, I happen to sit actually on a formation called the BRICS Business Council, which is a 25-person council. We're appointed by the President of the Republic. My counterparts in Russia, India, and China also appointed by their respective heads of state. And there has been extensive discussion within BRICS, the BRICS Business Council, that is, as recently as yesterday, with respect to how do we access, where they're suitable and appropriate, of course, and this is the point Professor Schoub made. There are lots of good vaccines out there. Some are appropriate for our country and others are not, and we've got to be evidence-based. We've got to lead with science in making those decisions. So we do introduce a bridge between the business aspect and the scientific aspect in those discussions at BRICS. And that is why the first vaccine that we secured, albeit unfortunately so, was the Astrozenica Serum Institute vaccine. And there I can tell you the Business Council did play some role in that. And we also know, because it's in the public domain now, that President Ramaphosa and his counterpart, Prime Minister Modi, also had discussions around this. So unquestionably, there was a benefit of being part of BRICS in securing the Serum Institute AstraZeneca product, albeit that unfortunately we found out later it wasn't suitable for our country. And there's similar discussions with the Russians and the Chinese. But we have to lead with the science. Sorry, I'm going to be repetitive around this, because if we're not science-led here, we're going to run into a problem, unfortunately.
Professor Schoub, this is a question from Paul Ash from the Sunday Times. Is there any new data on whether the presumed widespread number of infections, estimated around 40% of the SA population, has improved South Africa's chances of achieving herd immunity?
I think the bottom line answer is no. And the reason for that is that the measure of the so-called seroprevalence studies, which, as the name implies, it's the prevalence of antibodies in serum specimens, doesn't necessarily give an indication of the prevalence of immunity. We know that, for example, there's been, and this is cited so many times, the case study of Manaus, which is a city in the Amazon in South America. Now, Manaus, after their first wave of infection, they did a study of their blood donors, and they found that 76% of them had antibodies, 76%, which is almost everybody. And then a few months later, after that, they had a massive second wave, much bigger than the first wave. That was probably due to their variant, the so-called P1 variant of Brazil. But again, having all those antibodies didn't protect you against that variant. Now, in our situation, having 40% of individuals, these are certain studies done looking at antibodies in a clinical diagnostic test. You can't do a neutralization test, which is a much more refined way of testing immunity, because that's far too expensive, far too cumbersome. They do what's called an enzyme immunoassay test, and that doesn't necessarily pick up what we call neutralizing antibodies. So I think that 40% does not necessarily affect that 40% of individuals are immune. And we do know that we've collected so far over 4,000. I think that was actually a month ago. It's probably a lot more than 4,000 second infections from the first wave to the second. Now, that's probably to a large extent are the variants. But again, having antibodies doesn't necessarily protect you either against variants and probably also not against even homologous strains, the same variant, the same strain. So unfortunately, we can't rely on those seroprevalence. It's some kind of indication, but it's certainly you can't quantitatively rely on that, no.
Thank you, Professor Schoub. Dr. Dimitri, there was a question here as well about what your thoughts are in the way that South Africa is dealing with the pandemic versus what transpired in the UK. You know, here we went through a very hard lockdown, one of the most aggressive in the world. We always felt like, you know, we were able to overcome it relative to other nations. And then the second wave and the variant arrives. But what really struck me about your presentation, when you said you had to send people home, and that hospitals in the UK were at overcapacity, you know, last year, and again now you're dealing with a similar situation. You know, how do you compare? Do you watch back home and see what South Africa is doing, the real situation versus what's happening here?
Absolutely. I mean, I have friends and colleagues in the medical sector in SA, and I hear their challenges, and it echoes our challenges. I think before the first wave, we were looking at Italy, for example, and all the harrowing images coming out of Italy, and the government here, the sort of slogan to the public was protect the NHS, so stay at home, respect lockdown, and essentially protect the health service. So yes, absolutely. We had a tough first wave, and we've had a much tougher second wave. And as we start emerging from the second wave, and just listening to Prof, we're already talking about, will there be a third wave? I think Poland, for example, are experiencing or about to head into some kind of third wave. So this is the reality we're facing. It's been immensely challenging. I was on call on Boxing Day, and at one point we had ambulances that were queuing for about 6 hours to come into the emergency department. So I was seeing patients on the back of ambulances. This is the UK, a first world country with a lot of money. Do you know what I mean? So don't feel like in South Africa you've been neglected and it's been rosy here. It absolutely hasn't. It's been really tricky. And it's been tricky from an emotional point of view. My wife's an ICU consultant, and patients have been in ICU for 60 days. The emotional connection you make with those patients on a daily basis, and the extended families, and then to sadly see those patients die is just heart-wrenching. So as a healthcare sector, people are exhausted, we're emotionally drained, and we're still not kind of fully out of the dark. So that's kind of the feeling and the mood. So the vaccine is giving everyone a lot of hope, and I think this week the government was announcing a sort of road to recovery and a way of getting everyone out of lockdown. So it's been challenging on a number of fronts. Just also as a dad, and having to kind of do homeschooling and all of that, which again echoes all the challenges that people have faced in South Africa. It's similar, there are parallels.
Thank you very much for sharing that personal story. And I think it really drives home the fact that we have to, the people that are reticent to be vaccinated, they need to listen to these stories. And the vaccine, Stavros, would you say is our best hope? I'm going to get into a fact versus fiction scenario here because we've got a lot of misconceptions that have come through in our Q&A session. But Stavros, I want you to tell us in terms of how important this vaccine is going to be, because the private sector is thinking about it. People in boardrooms, everyone is thinking about how do we get through it.
So, Eleni, probably a good starting point here for me is, and I know you're a regular at WEF Davos, probably one of the most pronounced comments that came out of WEF last month, WEF Davos that is, was one of the CEOs said that the best economic policy for 2021 is to vaccinate. And I would agree wholeheartedly with that. So this is about saving lives and livelihoods. And we need a combination of vigilance around non-pharmaceutical measures, which Professor Schoub spoke about earlier. So we still need to do all the normal stuff, the social distancing, the masking, the hand sanitization, all those measures which are by now very well known. But we need to do away with the complacency, because what we find is when you start going on a downward trajectory, as we're experiencing presently in the second wave, then people let their guard down, and that's not a good thing. We need to be vigilant for a lot longer around the non-pharmaceutical measures. But unquestionably, the vaccine in combination with these non-pharmaceutical measures presents the best opportunity for us at a point in time to return to normality. And that's what we all want. We want to be back in a position where we were in December 2019, before we encountered this pandemic, and that's where we want to go to. So unquestionably, vaccines are a very effective tool. They've demonstrated this throughout history. They're very effective tools in turning the tide against pandemics, even the most contagious ones, like the one we're experiencing at present. And I just want to at the same time take this opportunity, because I know a lot of people are saying, and Professor Schoub did handle these questions earlier, they're saying, well, we've developed these in record quick time, 301 days for the first vaccine, etc., etc. It is a little curious that people are skeptical about vaccines when we've used vaccines for over a century, right? In some form or shape. So I think we need to keep a perspective that these are the same vaccines, maybe different technologies and different platforms, but they're the same. It's the same approach that we've used to eradicate things like polio and smallpox and various other pandemics throughout history. And that's why vaccines present a very good opportunity for getting us back to normality.
So we've got 15 minutes left, and I've got quite a few questions, but I want to get through the fact versus fiction segment, because we've got some interesting questions, and we kind of joke about the fact that people say Bill Gates wants to kill us, but there was a question that came through that, this is the kind of conspiracy theories that are bubbling under the surface and are really being had in all sorts of dining rooms. And there's a joke that we say in the financial industry, if your hairdresser is telling you to buy a stock, you have to absolutely sell instead of buying into the market, because if it gets to your hairdresser, then it's wrong. So you have the Bill Gates conspiracy theory. You've got the ivermectin kind of, big thing where people are popping these pills without there being trialed. You had the hydroxychloroquine story that came through. There's so many things that are happening. And Professor, what worries you the most of kind of the things that you're hearing on the sidelines while you're a science man and trying to focus on science?
Elena, it's interesting. There's obviously Corona has caused a lot of stress. People are stressed, they're worried for, and justifiably. And when people are faced with this kind of stress, three things happen. The one thing is people get comfort with conspiracy theories. Why? Because conspiracy theories, it's a sort of science fiction, and there's a sort of comfort in that. The second is that you look for wonder drugs. If it's chloroquine, or if it's ivermectin, for zinc and vitamin C, etc. So you look for a wonder drug. And the third thing is that you look to blame. Who do you blame? Who can you blame? So it's blame, conspiracy, and wonder drugs. Those are when people are insecure, and I think we need to look. I'll tell you the one thing: us healthcare professionals are not good communicators. We're not. We need people like you, Elena, to help us kind of get the message across to the population. The media plays such a pivotal role. The media can be a force for negative, and unfortunately, to some extent in this country, they have been. You've got to admit that. And they can be a force for positive. And I think the media really do have a social responsibility to kind of handle people's questions and people's discomfort. Getting information, good, authentic, scientifically based, provable scientific information, and handing it over to the public in a way that the public will appreciate what is being given to you. The media are really that interface.
So hold on, Professor Schoub, you're saying that when you are advising government and you're leading the ministerial committee for COVID-19 vaccines, there isn't a conspiracy to try and control us all?
Well, now that you mention it.
Is that what you guys are doing, concocting, I mean, look, seriously, listen, I'm telling you, especially the older generation, they're reading off Facebook, they're reading articles, and you're getting these concerns, and they really are worried. They're scared. They're afraid. What are you talking about?
I wish I could take a camera into SAPRA, which is the regulatory authority. As I say, I've been involved in it. And to show you the dossiers and how meticulously they've gone through, there is no way you could smuggle a microchip into there. You couldn't smuggle a nanochip. You couldn't study something which is less than a nanochip. It is impossible.
All right. So, Dr. Dimitri, ivermectin. I have to talk about this because I have very wealthy, intelligent, learned friends that are popping the pills. So for those, the question came through. So tell me.
To my knowledge, no benefit. The trials I mentioned in the presentation are the biggest trials. Remap CAP is a multinational trial. So European countries, China, North America, etc. So these are big trials, 22,000 patients, 10,000 patients, etc. And that's where this data is coming from. And like Prof says, it's hard to sometimes translate the data and the figures and to communicate that to patients and to the public, and that's where, as scientists, as doctors, we fall short. And also, there's a lot of COVID data. There's a lot of COVID research going on. So to go back to ivermectin, nothing to my knowledge so far. I'm not too sure if there is a big trial looking at it. I wouldn't be surprised if there is. I think, as I mentioned in my talk, the immune modulating drugs, so Toxi and Barry White, we call it, those are showing some promise. But again, it's a cheap drug like dexamethasone, which is as cheap as chips, which is shown to be effective, and the modalities like oxygen and being very careful and precise with when we put a patient on a ventilator and when we use the non-invasive ventilation method. So we've learned a lot, but we've got to rely on the evidence. Stavros was saying we've got to be scientific about this. The one good thing about the UK government is at the very start of the pandemic, it kind of took off all restrictions on research and ensured that research was promoted. So there was a lot of COVID research and science and data being generated. So it kind of embraced science, if you will. So yes, that's the one good thing that the UK government did, was to kind of embrace science and embrace the scientific community, and to perhaps go back to your former question about what can South Africa do. I think it's for you guys, for Prof, for Stavro, who's sitting on all of these committees, is to ensure that the government is listening to the science and the data, and then translating that to the public and communicating it effectively.
So Stavro, you can comment on all the myths I've just mentioned, but I also have another question for you in terms of what business can do, because and Dr. Dimitri is right. You're on so many boards. I know you barely sleep because you're working so hard, working with the private sector, working to find solutions to the problems facing this country. I want you to tell me what you think business can do.
Eleni, business can do three things. I think the first thing is we represent a substantial constituency in this country. So I think first and foremost, concise, accurate, and timeless information is critical. The ivermectin and hydroxychloroquine debate spilled over into business, and to a degree, these discourses in the public domain are polarizing. But we've got to make sure, and business is doing this, that we are evidence-led at all times. There's no bigger enemy, or probably as big an enemy as the pandemic itself, is when you start applying anecdotal incidences or events or experiences to science. It just cannot work that way, and we've just got to caution against that. So accurate, concise information, number one, business is doing. Number two, business has extensive resources. The private sector has extensive resources. We have made these resources available through the Business for South Africa formation to government. We're very clear, however, we are not leading the program. It's for our government here in this country and any government around the world. They need to lead the vaccine rollout initiative. What we can do is complement, support, and assist where we can with the private sector infrastructure and resourcing. And then the third thing, of course, is business and the private sector have extensive medical resources, but also other competencies and capabilities in manufacturing. We've made available a platform, a panel of lawyers to assist government with the contracting aspect. We've got massive funders in our group that have been able to cost this program. And that's why we've said the vaccine program in South Africa, annualized, is going to cost between 11 and 15 billion rand. That's how we've costed it out. Now, last year, our economy lost 380 billion rand. So 15 billion rand is a rounding error in the broader scheme of things. So these are the things that business can do to A, set the record straight on certain misconceptions and misrepresentations, and B, we can bring our resources to the fore to assist both infrastructurally and also where there are problems that need to be sorted out, we can play a pivotal role in that.
Stavro, I've got another question for you regarding corruption. And that's also been so disheartening for so many South Africans, where we saw money, literally flying out of the window, and people lining their pockets. And again, it just comes down to trust. So we know this is going to be expensive. How can we be assured that business or, unscrupulous elements within government and in the business community are not going to be trying to steal?
So Eleni, I think the concerns and anxieties are fully justified. We saw some of the most atrocious behavior during the first wave, particularly with the procurement of PPE. And all of those stories are well known. I would say they're outrageous, and I never cease to be amazed at the level of greed that took place at that time. Now, of course, we cannot afford a repeat in the second wave. We've now moved off the second wave. We cannot afford a repeat as we roll out the vaccine. So here's a couple of things that we're doing as the private sector, because we understand that at the end of the day, all that corruption is doing, it's depriving poor people of services in our country, whether it's access to a vaccine or basic running water, whatever it might be. So The procurement of the vaccines is going to happen by government, so that raises a red flag already. The good thing, however, is the following, that there are a limited number of suppliers that have credible vaccines that are going to be registered in this country. So that already narrows down the number of people that you're dealing with. It's not like the PPEs where people that were owning garages were coming to the fore and trying to sell PPE. And it wasn't incidentally tested PPE because PPE needed to be tested, the quality requirements as well. So what gives me some comfort is now you're going to be dealing with between, let's say, in the first year, 3 to 7 manufacturers. The second thing is we have an agreement as the private sector now with government. Business for South Africa sits in a 3-a-side committee with Treasury and the Health Department. So the DG of Treasury, DG of the Health Department and ourselves, we sit in this meeting every Monday. They've agreed that we can have observer status with respect to having access to viewing these contracts to the extent that we can, of course, and also, more importantly, we can have visibility and line of sight of the procurement process. So we will, where necessary, we will raise the alarm bells. If we need to get an opinion through an auditing firm because we think there might be some malfeasance, then we will do that. Now that's quite a radical departure from where we were in the first wave. So some of these interventions, they don't give me absolute full comfort, but they're certainly a strong step in the right direction, I believe.
Thank you. Professor Schoub, there's a few questions on insurance companies and protection liability against the use of vaccines. And I think they're quite interesting. So the one is, are the pharmaceutical companies going to provide injury liability? Is this something you guys are asking for, perhaps? And then the other question on insurance companies says that in South Africa, they are not insuring anyone for adverse effects arising from vaccine use that may affect income earning ability. Any way around this problem? I mean, it comes down to the safety of vaccines and driving that message home. What message would you have for people that really are afraid of adverse effects?
Well, the only thing I can, unfortunately, I think Stavros is probably more competent to talk about the liability and the insurance and so on. That's a bitty baker my firma plek, as I say in Afrikaans. But with regard to side effects, yeah, you know, as I said earlier on, you know, I think so far, I don't know how many million doses, so I think the figure would probably be about 40 or 50 have been rolled out across the world, and plus the safety prior to that, and the incidence of side effects has been incredibly low. The only real serious side effects have been serious allergies, what you call anaphylaxis, which has been actually reported with the Pfizer and Moderna. And there the incidence is about 4 to 5 per million doses. None of them have been fatal, they've all been treated, but there are obviously serious side effects. And that's really been the only serious side effect that has been monitored in the millions of doses which have been rolled out so far. So these are remarkably, and I'm saying all of them, are remarkably safe vaccines. So I think serious side effects are going to be an extreme rarity with these vaccines. They seem to be even more safe than all the other vaccines that we've been using up to now.
All right, fantastic. We're running out of time, so I want to wrap with just closing statements and the message you have to our audience and those that are feeling reticent, that are feeling afraid, that are reading way too much information on conspiracy theories and are generally afraid. I mean, the kind of questions we get, you know, I've had COVID, am I going to get it again? Should I even get vaccinated? If I have COVID, can I get a vaccine? What vaccine should I get? Can I trust the government that they've done the background research? Should we trust something from China? Should we trust something from Russia? How do we look at all of this from a macro perspective and holistically? Because we've said from the beginning of the pandemic, and the World Health Organization has said this, leading doctors have said this, if we don't work together, the world is not going to recover from this anytime soon. So, Dr. Dimitri, I'd like to start with you.
Yeah, without a doubt. I mean, I think this virus has shown how interconnected we all are, and how it's impacted, you know, every corner of the globe. I think maybe just drawing parallels between South Africa and perhaps the perception in South Africa and the UK about how this whole thing's been handled. I think if I look at the issues in the UK, again, Stavros mentioned on the PPE fiasco in South Africa, there was a PPE fiasco in the UK. I got a COVID infection in March last year, and a lot of it was because I was poorly protected. So the government failed healthcare workers in the NHS. Point of care testing, mentioned in my presentation, it would take us 4 to 5 days to get a COVID result. Operationally, it messed us over. You know, it was just not sustainable. Now we can get a result within 30 to 60 minutes. The public message here has been at times mixed and confusing and delayed. There were delays with border closures. The government spent £500 million on Nightingale hospitals, these big field hospitals. The patients who were treated in these hospitals was a minority at an expense of about £1 million per patient, and these were moderate COVID infections. The NHS test and trace system has been a fiasco. So I think to kind of draw parallels and to maybe say to my friends and my colleagues in South Africa that and I don't know the details in South Africa, but if you're looking to the UK to say this was the gold standard approach for managing a pandemic, don't look at the UK. And the things that they have done well, as I mentioned, was engagement with the scientific community and promoting research and garnering good data, and the vaccine program, which so far seems to be working well. Those are the elements that have kind of worked well. But I have no doubt, as I said to you, Eleni, before when we were briefing, that the public here are crying for and are demanding an inquiry when this is all over. So I'm pretty sure that's what the UK government will have to face after this pandemic, hopefully.
Quick last question to you, Dr. Dimitri. Are you feeling optimistic that we are getting closer to the end of this?
I'm a glass half full kind of guy, so I am feeling optimistic. I think I was in South Africa in February last year. I had a great time, and flying out apprehensively, knowing I was bracing myself for a first wave of pandemic. And I feel that we know so much more 12 months later. We know what works and what doesn't work. We've got lots of trials underway, so we'll know even more in the next couple of months. We have a vaccine. We have multiple vaccine. Prof was saying there's over 100. So I feel confident, but I don't think we're out of the dark. I don't think we're out of the woods. And I think I'm echoing what the Prof has been saying and other virologists, is that this is probably going to stay with us for a while with mutations, and possibly sort of annual vaccination, and I think it's heading to it becoming endemic. So, but I think if we have vaccines that we can tweak and work with, and that's a good position to be in. Thank you
so much, Stavros.
So Eleni, I'm also a glass half full guy. And I think
little sleep over a year. I'm surprised.
Exactly. So I am looking forward to sleeping sometime soon. So I am staying optimistic, of course. I think, Eleni, we need to. I'd like to make 3 points in terms of how I see the future here. Not that I've got a crystal ball that I can gaze into. No one really does. But I think it's a safe bet, I would say, that this is going to be with us for some time still to come, and we need to take the positives about what is emerging here. So, firstly, I've seen on the non-medical side, I've seen business and government and labour, for that matter, in our country cooperate at levels that I haven't seen before. Now, that's very important for all the business people on this call, because we've got a public health crisis we're dealing with, but we've also got an economic crisis that we're dealing with. And the two are so interrelated that you cannot for a minute talk about the one without the other. So those aspects are important because they give me a lot of hope around how we manage the economy futuristically. So I think that's the first positive I would like to take out of this. The second positive is we know so much more about, there's a lot we don't know, by the way. And I think Professor Schoub's contemporary, Professor Slim Karim, he often says, they're no COVID experts, and anyone that tells you they're an expert, they're probably lying. Okay. I think there are experts, but we don't know a lot about this. But geez, have we learned a lot? I can't recall any other disease where we've learned so much about a disease in 11 or 12 months that we have with COVID. So our ability to manage patients and also to roll out a vaccine, we're learning all the time, and that's going to get better all along as we move on. And then the third and final point that I want to make is this has also taught us in our country how to repurpose and how to pivot. So pivot's become a buzzword. We haven't used it for many years, and it's really become a fantastic word to use at the moment, because I've seen ordinary South Africans whose businesses have been going down the drain pivot into a new direction, and they're surviving. Now, hopefully many entrepreneurs out there can start learning from this, and we can start pivoting. And if I just look at what my own company where I work, what Aspen has done, Aspen had sterile capabilities, and it was able to take a sizable portion of it and make it available to solve a problem, not only here in our country, but also globally. So those are all the positives that we need to take out of this. And lastly, the biggest positive for me right now is we have got 43,000, I just looked at the number now. We've got 43,000 vaccines under our belt in our country. We've kickstarted the program. There are no more delays. We made an incredible, to get this Johnson & Johnson research trial, they were research trial doses. Our colleagues, including Professor Schoub and his team, the government, Medical Research Council, in 48 hours solved the AstraZeneca problem that we were presented with. So these are all immensely positive things, and I think the outlook is positive, and I think we will have a very good shot, excuse the pun, at vaccinating the aspirant 40 million over the next 12 to 18 months.
That's great news, Stavros. Thank you very much. Professor Schoub, I hope you have an optimistic outlook for me as well.
Yeah, Eleni, I do. I actually, I'll go further. So I'm actually a full glass guy, not a half glass guy. But having said that, we've spoken a lot about vaccines, and clearly vaccines, I mean, I am a vaccinologist, and I started the National Advisory of Immunization. So I'm very much in the vaccine camp. But I think what we do need to realize that vaccines are not a magic wand, not a silver bullet. It's not going to switch off the epidemic. We still got, and we see it in countries like the United Kingdom and many European countries, a country like Israel, for example, which is leading the world in terms of the percentage of individuals that have been vaccinated, that it hasn't switched off the epidemic. We're still going to rely on these non-pharmaceutical interventions. I think that's the measure I still want to get across, that certainly for the year 2021, we cannot afford to drop these. Now, the vaccines, the COVID vaccines are not nearly as effective as, for example, measles vaccine is. Extremely effective vaccine. But COVID vaccines don't reach that level. We're still going to rely on the non-pharmaceutical interventions, the masking, the physical distancing, all those, the avoiding of social gatherings and parties and so on, all those super spreading things, even when we have a vaccination program in place. And certainly for this year, the two are going to go hand in hand to get to that level of herd immunity. Once we reach herd immunity, yes, once we reach herd immunity and it's no longer a new virus to the human population, then we can relax. Hopefully we'll still retain some of these good habits. The Orientals for centuries now, when they have an upper respiratory tract infection, they have a cold and they're in public, they'll have a mask. And we Occidentals, we don't do that. And maybe now some of those habits will rub off on us. That if you've got a cold, if you've got a streaming nose and so on, and you're in a public place and you're in a shopping center and a mall, you will wear a mask, because now wearing a mask, you're not going to be so scarred because you're wearing a mask. and hopefully some of those habits will carry on, even into 2022 and so on. But I am optimistic. I think with a combination, and I must stress, the combination of the non-pharmaceutical interventions plus the vaccine rollout, we will reach a level of control, not saying herd immunity, of control. But I think we will eventually need to tolerate this virus. We can, and we can. We've got 4 endemic coronaviruses which cause the common cold every year. You probably didn't even know about it. Most people didn't know about it. As Dr. Dimitri, I think it was about 25 seconds worth of lecturing time in 5th year or 3rd year, maybe not more than that. And maybe this particular coronavirus, the SARS-CoV-2, will become one of those endemic viruses which we can tolerate. We can tolerate mild upper respiratory tract infection. What we can't tolerate is for moderate and certainly severe, because that is what overwhelms the hospitals, that is what kiboshes our economy and so on. But we can control, and I think we will, and I think we will need to tolerate this virus, but at a very, very much more trivial level. And that's not going to be too bad. It's just going to be another one of the hundreds of viruses which cause mild upper respiratory tract infection, the common cold. And that's my optimistic view. I think 2021, vaccine and non-pharmaceutical interventions. 2022, we can then start, maybe the 2nd generation vaccines will come about, which can deal with the variants. And maybe there will be regular vaccination, maybe not annually, but regular vaccinations. And then we will get these breakthroughs of mild infections. That virus will not disappear. There's only one virus which so far has disappeared, smallpox. No other virus so far. Polio is on the way, but not quite there yet. But coronavirus, no, not in our lifetime will that virus disappear. We'll still have it. We'll tolerate it.
You're optimistic, but yet you threw the biggest truth bomb I've heard in a while, that coronavirus is going to be with us for a very long time. Professor, I'm going to have to leave it there. Thank you very much for your time. Professor Barry Schoub, Dr. Dimitri Kontogeorgis, and Stavros Nicolaou from Aspen. Thank you very much for joining us. Thank you very much for your insights. I hope to you, the audience, it's been helpful that we've answered some of your questions. We've tackled some of the myths, some of the realities, and perhaps also motivated why getting involved in the vaccine program is going to be vital in being able to get our lives and our livelihoods back. Thank you very much for joining us, and a big thank you to the Hellenic Federation and of course the Federation of the Hellenic Federation, as well as the Italian Portuguese Alliance. Thank you very much for joining us.
Thanks very much.
Thank you very much. Thanks for having us.
Thanks.
Take care.
Thank you. All the best.